Hi Mo.
Hello, can you hear me?
Yeah, I can hear you now.
Okay, perfect. Okay, so I'll probably start the presentation now. Let me start. Let me quickly. Yeah. Okay, so this talk today is going to be on asthma and anesthetics. So what I'll do first of all, I'll try to in the slides I'll incorporate all the part A you need to know, but on top of that I'll include quite a lot of part B content, as these topics frequently come up in in exam questions. So I want to give you guys sufficient material to be able to tackle the most common questions for asthma and for anesthetics. And I'm Mo, and I'm a fourth year medical student at Lincoln. So this is what you need to know in terms of your syllabus for asthma. And just to briefly give some information about asthma. So asthma can be defined as a recurrent reversible airway obstruction. And there's two main types of asthma. So you've got extrinsic asthma, which is also referred to as atopic asthma. Atopic just means allergic, so allergic asthma. And this is triggered by exposure to an allergen, such as, for example, animal fur or grass pollen. And typically, a patient with allergic asthma can have some other allergies or autoimmune conditions, such as hay fever or psoriasis. And then the second type is intrinsic or non-atopic, non-allergic asthma. And this is triggered by non-allergen causes, such as exercise, cold air, or anxiety. And childhood onset asthma tends to usually be more allergic, and adulthood onset asthma is usually tends to be intrinsic or non-atopic, and it's more difficult to control. And in terms of the acute asthma symptoms that a patient might experience during their asthma attack, it includes dyspnea, which basically means breathlessness. And in the early phases, it's due to the inflammation that we're going to cover in the next few slides, which causes pulmonary edema and not due to hypoxemia. And patients having an acute asthma attack can also have a wheeze on exhalation and also a cough, which is particularly pronounced at the end of the asthma attack. And throughout the slides also, I'll be doing some brief comparisons with COPD, as it's a common exam Part B question where you have to compare asthma and COPD. So in comparison, COPD is an irreversible progressive airway obstruction, and one of the biggest causes is usually smoking. So in terms of the pathophysiology of allergic asthma, so you have your allergen presentation, which the person is allergic to. It's presented by a dendritic cell to your T helper cells, and that stimulates the differentiation of the T helper cell into a T helper 2 cell. And these T helper 2 cells really drives the pathology as they release IL-4, IL-5, and IL-13 cytokines. And the IL-5 and IL-13 cytokines stimulates eosinophil maturation in the bone marrow, and it also stimulates their recruitment to the lung airways. And in the lung airways, they secrete proteases and perforins, which damages the bronchial epithelium. And another important cytokine is IL-13, which acts on the goblet cells to produce mucus in the airway. And it also sensitizes the airways to smooth muscle cell contraction, which causes the bronchoconstriction. And then you've got IL-4, which activates B cell class switching, and these B cells produce IgE. And then those IgE antibodies will then bind to the surface of mast cells, and these mast cells will be present in the airways, so that upon exposure of the allergen, it's going to bind to the IgE on the surface of the mast cell and stimulate the mast cell to degranulate, and that causes the release of histamine, and the release of histamine will cause some of the pathologies that we're going to describe in the next slides. And in comparison, for intrinsic non-atopic asthma, the mechanism is less well understood. So in terms of the pathophysiology of an acute asthma attack, the mechanisms we described, so you have bronchoconstriction, and this is due to histamine release and also the inflammation. And then also you have inflammatory airway edema, which further reduces the airway diameter on top of the bronchoconstriction. And then you've got inflammatory mucus formation. And this mucus is initially aqueous in nature, but as the asthma attack worsens because of sympathetic nervous system activity, it becomes more viscous. And if I can direct your attention to the graph on the right, this outlines the changes in pH and CO2 during an asthma attack. So initially, the patient is hyperventilating during the asthma attack, and this is because of the edema, which is stretching the pulmonary tissue, and this is being sensed by receptors in the pulmonary tissue, which causes that hyperventilation. And what happens is you see there's a decrease in blood CO2 levels, and you also see an increase in pH, and this is just a respiratory alkalemia. And then afterwards, as the viscous mucus is being produced, because for most patients, their asthma attack isn't as severe, so it stops at this point. But for people who have a more severe asthma attack, then you start to see viscous mucus formation, and this impairs gas exchanges, and viscous mucus much less readily enables CO2 to go through it compared to aqueous mucus. And so the patient begins to retain CO2, and so you go on this upwards trajectory, and the pH begins to decrease. And this is clinically relevant because if you see a patient and you take their arterial blood gas and it's a normal PCO2, then this indicates that it's probably a life-threatening attack. They're probably like on the upward trajectory, and they're going to have hypercapnia soon, they're going to have a high blood CO2. So you should probably like admit the patient to intensive care. So in terms of the diagnosis, it's made based on the symptoms that the patient is exhibiting. And also, for example, for allergic asthma, you can have clues in the patient history, such as, for example, if they have other allergic conditions such as hay fever and psoriasis, it tends to go in hand with asthma. But some more objective measurements you can take is you can perform spirometry. So if you can see the diagram on the top right, what happens is you take a deep breath in and you blow into the tube as fast and as you blow into the tube for approximately a couple of seconds. And what happens is the spirometer then measures the FEV1 to FVC ratio. FEV1 is the gas volume that's exhaled in the first second, and FVC is forced vital capacity, and it's the total gas volume exhaled. And if it's less than 70% whilst the patient is symptomatic, then that can be indicative of asthma. But it's also important to note that a normal spirometry reading doesn't rule out asthma, as most asthmatic patients outside of asthma attack periods can sometimes produce FEV1 to FVC ratios that are normal. And another test you can do on top is a bronchodilator reversibility test. So you make the patient initially perform their spirometer reading, then afterwards you repeat it after you've administered a bronchodilator. And for asthmatic patients, it tends to improve their FEV1 by greater than 12%, and there's a 200 milliliter at least increase in volume of the FEV1. And another thing you can do, another test, is peak expiratory flow readings. So what happens is the patient measures their peak expiratory flow twice daily for a period of 2 to 4 weeks. And the way in which this is measured is that a patient takes a deep breath in and then blows as fast and as hard as possible into the peak flow meter over here. And a greater than 20% diurnal variability, i.e. you're taking the like highest measurement and the lowest measurement and seeing the percentage variability. If it's greater than 20%, it's indicative of asthma. And just to contrast it with COPD diagnosis, the COPD diagnosis is made based on clinical features, and importantly, they usually perform the spirometer test, and the FEV1 to FVC ratio is less than 70%, and that's even after administering a bronchodilator. And also compared to asthma, because as we mentioned previously, it's irreversible and progressive, you see a progressive decline in the FEV1 to FVC ratio as the disease worsens. And this FEV1 to FVC ratio in itself is used to stage COPD. So in terms of the treatments for asthma, there's two main types. So there's bronchodilators and anti-inflammatory drugs. So bronchodilators are used to symptomatically relieve an acute asthma attack, but it doesn't affect that underlying inflammatory chronic disease process that we outlined earlier. And the drugs which you need to know for your Part A exams are salbutamol, ipratropium, and aminophylline. And then in contrast, anti-inflammatory drugs aims to control that underlying inflammatory disease process, and in doing so, to attempt to reduce the frequency of acute asthma attacks. And anti-inflammatory drugs have little effect on the acute asthma symptoms. It's to reduce acute asthma attack frequency. And in terms of drugs, we've got glucocorticoids such as prednisolone and beclomethasone, which are used. And also there's these two drugs which we're going to cover, but it's more like Part B. So there's leukotriene antagonists and asthma biologics. So in terms of asthma treatments, in terms of short-acting bronchodilators, you've got salbutamol. So it's a beta-2 agonist. It binds to your smooth muscle cell beta-2 receptors in the airway, and then it activates that cascade where you activate GS protein, increase CMP, cyclic AMP, and then you cause all those downstream effects. And ultimately, it results in the airway smooth muscle cells relaxing, and this results in bronchodilation. And that's why it's used for asthma attacks where you've got that bronchoconstriction. And this is often administered through the blue inhaler. And in terms of side effects you can get, it includes facial flushing, tremor, and palpitations. And it can also cause anxiety. And if the patient's asthma is driven by anxiety, it can sort of cause a vicious circle. So that's important to consider. Some other issues is that some patients might have a beta-1 polymorphism that also responds to salbutamol. So they can experience more side effects because the salbutamol is binding to beta-1 and causing the side effects linked to that. And also the overuse of salbutamol can lead to the downregulation of beta-2 receptors on the smooth muscle cells, and that can consequently reduce the effectiveness of the salbutamol usage during an acute asthma attack. So other bronchodilators, we've got ipratropium, that's a muscarinic antagonist, and it blocks smooth muscle cell M3 muscarinic receptors. So what happens is usually all the time you've got a low level of acetylcholine that's released from postganglionic cells, which maintains the tone of the airway. And by blocking those receptors, what you're doing essentially is you're trying to block that cholinergic basal tone so that it leads to overall smooth muscle cell relaxation and hence bronchodilation. And this is administered via an inhaler. And then finally, you've got aminophylline, which is a methylxanthine. And methylxanthines are phosphodiesterase inhibitors, i.e. what they do is phosphodiesterase usually breaks down cyclic AMP as an enzyme at the end. So what happens is as you administer aminophylline, what happens is it amplifies the beta adrenergic stimulation as stimulating the beta adrenergic receptors increases CMP. And by blocking phosphodiesterase, you're prolonging the impact of the beta adrenergic drugs. And however, this is only used in severe and life-threatening asthma, and it's administered intravenously in hospital. And finally, moving on to the anti-inflammatory drugs for asthma, you've got corticosteroids. So if I can direct your attention to this diagram, what corticosteroids do is that it inhibits phospholipase A2. So you're inhibiting phospholipid conversion into arachidonic acid. And in doing so, you're preventing the downstream pathways that produce prostaglandins, as well as the pathways that produce leukotrienes. And hence you're immunosuppressing, you're suppressing cytokine production, and hence you're reducing neutrophil and eosinophil activity. And there's two types of drugs which are generally used. You use them as part of the brown inhaler. You use beclomethasone for mild to moderate asthma, but for more severe asthma, you use prednisolone, which is administered orally. And beclomethasone is the one you need to know for your Part A exam. And in terms of side effects, because corticosteroids are immunosuppressants, there's an increased infection risk. And this increased infection risk is systemic if you administer prednisolone orally, and it's more localized to the airways if you use beclomethasone via an inhaler. And in terms of the side effects, if you use it orally, they include edema, mood changes, muscle wasting, and osteoporosis. And if you contrast this with COPD, these steroids are only used orally, and they're only used for acute exacerbation. So when the patient's symptoms suddenly become worse, usually due to a respiratory viral or bacterial infection. So now moving on to leukotriene antagonists, these include zafirlukast and montelukast. And what they do is they suppress the production of leukotrienes. So they're suppressing leukotriene production here. However, it's a lot less used versus glucocorticoids clinically. And this is because although having leukotriene antagonists, they have less side effects, they're a lot less powerful as they're not inhibiting this pathway that importantly produces prostaglandins, which is quite a strong inflammatory driver. And so you're causing less cytokine suppression, and hence you're not producing as strong of an anti-inflammatory effect. So it's going to be less effective for your asthma. And now finally moving on to asthma biologics. So just to recap, in terms of eosinophils, some asthmatic patients do have chronically elevated airway eosinophils, and also eosinophils that are more prone to degranulation. And this is more commonly seen in allergic asthma patients. And what asthma biologics are is that they're monoclonal antibodies which are used in uncontrolled severe asthma. And the way in which they're administered is subcutaneously, and the patient can administer that at home. And in terms of asthma biologics that are used for severe allergic asthma, this includes omalizumab, which is an anti-IgE antibody. So trying to stop that mast cell contribution to the asthma pathophysiology. And for severe eosinophilic asthma, you can use mepolizumab, which is an anti-IL-5 antibody. And so by blocking IL-5, you're blocking eosinophil activity. and benralizumab, which is an anti-IL-5 receptor alpha antibody, and basically blocks that receptor on eosinophils that responds to IL-5. So you're getting less eosinophil activation. And the requirements to be prescribed eosinophilic asthma biologics, because they're really expensive, is that you need to have a high blood eosinophil count, aka you're showing that the asthma is predominantly being driven by eosinophils for that patient. And also the patient needs to have had frequent exacerbations requiring oral steroids in the past 12 months, which suggests that their asthma is a bit more severe and it's less well controlled. So that's it for asthma. So moving on to anesthetics, this is what you need to know. This is the syllabus. And these are some past paper questions related to anesthetics on the part B side. And as you can see, they tend to focus on three main topics. So we'll be going into these in depth. So it's focusing on anesthesia induction and maintenance. Also, there seems to be some questions that look at the hypotheses of the mechanisms of action. This is purely part B, hypotheses of mechanisms of action. It's not on your part A syllabus. And the final one is the physiological challenges of anesthesia and how they're managed by anesthetists. So we're going to go in these three. We're going to do all the part A content, and then we're going to go into the part B content in depth. So in terms of anesthetics pre-induction, so before you put the patient to sleep, you can give them anxiolytics such as temazepam, which is a benzodiazepine, and you administer this to calm the patient down. You can also give neuromuscular blocking agents such as atracurium and succinylcholine, and these are important because they facilitate skeletal muscle relaxation and they cause short-term paralysis, which facilitates tracheal intubation. And you reverse at the end of the operation this paralysis by using anticholinesterases such as neostigmine. And finally, you can administer antiemetics before putting them to sleep or even during the maintenance phase, such as you can use drugs such as ondansetron. And the way in which they work is they reduce post-operative nausea and vomiting by being a 5-HT3 antagonist. So in terms of induction, so putting the patient to sleep, so IV anesthetics tend to be preferred over inhalational anesthetics because IV anesthetics have a more rapid onset, and the most used drug is propofol. And another benefit of propofol, another desirable property is that it has a rapid clearance rate from the plasma due to its rapid redistribution from the central nervous system into muscle and adipose. And it also has a rapid metabolic clearance rate, which overall leads to a rapid recovery for the patient. However, disadvantages of propofol use is that it only has mild analgesic properties. Hence, you need to co-administer opioids for painful procedures when you're using propofol. And also it has a low water solubility, which means that it needs to be administered as an oil and water suspension. And this can sometimes cause pain at the injection site for the patient. So in terms of maintenance, inhalational anesthetics are generally used, such as sevoflurane, isoflurane, or desflurane. So sevoflurane is currently the most used one, as it's less irritating to the airways. And if you compare it to isoflurane, it has less respiratory depression. And another new emerging reason is also sevoflurane contributes less to global warming compared to the other inhalational anesthetics. So it's becoming also a more desirable volatile anesthetic to use in this context. And just to clarify, volatile anesthetic literally means inhalational anesthetic. So they're interchangeable. And you can also administer nitrous oxides. And what it does is it reduces the required doses of the inhalational anesthetics that you're using. And so this is desirable because then you get less cardiorespiratory depression, because as we'll outline later, the inhalational anesthetics cause cardiorespiratory depression. And also another desirable property is that it has analgesic properties. However, its low potency means that you can't use it alone for procedures. You need to administer the other inhalational anesthetics. And in terms of a really rare adverse effect that you can get from inhalational anesthetics, this is malignant hyperthermia. So the mechanism is what happens is you have excessive skeletal muscle, sarcoplasmic reticulum, calcium release in response to that volatile anesthetic. And what happens is you get sustained muscle contraction, and so you get excessive heat released, and this causes hypothermia. And susceptibility to malignant hypothermia seems to be due to a genetic mutation in the ryanodine receptor, gene, and the ryanodine receptor, as you can see on this diagram, controls the release of calcium from the sarcoplasmic reticulum. And the treatment for malignant hyperthermia, if it arises during an operation, is dantrolene, which is a ryanodine receptor 1 antagonist. But like I said, it's a really rare adverse effect. So now moving on to hypotheses of the mechanisms of action of anesthetics. This is all Part B content, but it can be useful to revise in case it comes up in your essays. This is the lipid theory. So just to give, this is a Part A definition, in contrast, minimum alveolar concentration. And this is the minimum concentration of anesthetic vapor in the lungs that's sufficient to generate a loss of motor response in 50% of subjects, i.e. MAC is measuring the potency of an inhalational anesthetic. And if your anesthetic, your inhalational anesthetic is more potent, then it has a lower MAC. So the lipid theory basically was devised based on this observation that you can see on this graph, that basically the anesthetics, the efficacy of it is related to how lipophilic they are. So on the x-axis, you've got olive oil water partition coefficient, which is a measure of how lipophilic it is. And basically, the greater the number, the more lipophilic it is. And on the y-axis, this is basically measuring MAC. So the lower down it is, the more potent it is. And as you can see, there seems to be like a nice linear trend where the higher, where the more lipophilic the agent is, the more potent it is, and the lower the MAC score. And so theoretical mechanisms for the lipid theory is that more lipophilic anesthetic agents, they're more able to readily get into that phospholipid bilayer and hence affect the membrane properties. And it's thought that maybe they increase membrane fluidity, or they cause a greater membrane expansion, and hence they cause more channel disruption, which leads to the anesthesia. And evidence against the lipid theory is that enantiomers of many general anesthetics have different clinical effects. So enantiomers, just to refresh from A-level chemistry, it's two molecules that are mirror images of each other. And so theoretically, they should have very similar lipophilic indexes. So for example, etomidate, the R enantiomer is 10 times more potent in potentiating GABA receptor activity versus the S enantiomer. And also another problem with this theory is that one of the thoughts is that increases membrane fluidity. And when you measure the increase of membrane fluidization by most anesthetics, it's equivalent to a 1 degree temperature rise. Yet if you do modest temperature rises, it doesn't cause anesthesia in itself. And the other hypothesis, which is a bit more popular, is the interactions with ion channels. And it states that anesthetics have got diffuse binding and action, and they alter the activity of the nervous system through increasing the activity of inhibitory receptors and decreasing the activity of excitatory receptors. And evidence for is that you've got certain anesthetics, such as nitrous oxide, isoflurane, and ketamine, which work through inhibiting excitatory glutamatergic NMDA receptors. And quite an important receptor in this theory is the GABA receptor. So the GABA receptor's got 2 alpha, 2 beta, and 1 gamma subunits. And the way it works is that when you activate it, it causes chloride influx, and hence it hyperpolarizes the neuron. It switches it off. And it's for also in using the GABA that these different subunits, as different anesthetics seem to act on different subunits and have different interactions with the GABA receptor, it could account for the diverse effects of anesthetics. So for an example, propofol potentiates GABA receptors through binding to their beta subunit, but certain volatile anesthetics, the way they work is they bind to the alpha subunit, and they have different binding behaviors between them. And you've also got volatile anesthetics. They cause neuronal hyperpolarization through activating 2-pore domain potassium channels, which adds to the interaction with ion channel theory. However, the evidence against is that it doesn't fully explain that correlation that we saw in the previous slide between lipid solubility and anesthetic potency. Hence, overall, it's likely to be a mixture of anesthetics, both influencing membranes and ion channel behaviors, that's accounting for the anesthesia that we see. Okay, now finally, we're going to cover the effects of anesthesia on the body systems. So we're going to look at cardiovascular depression that the anesthetics cause. We're also going to be looking at the effects of anesthetics on the respiratory system And finally, we're going to look at the effects of anesthetics on the thermoregulatory system. So in terms of cardiovascular conduction and contractility, volatile anesthetics directly affect the myocardium's ability to conduct impulses and also to contract. So if you take an example of a volatile anesthetic, halothane, low doses of halothane prolongs the PR interval. PR interval being between the start of atrial depolarization and ventricular depolarization, and i.e. It causes a longer AVN conduction, and low doses also prolongs the RR interval, i.e. It reduces heart rate, presumably due to a reduction in SAN activity. And if you take high doses of halothane, it causes a complete heart block, and there'd be no conduction through the AVN if you had to theoretically give a high dose. And the reduction in cardiac contractility of the volatile anesthetics is thought to be through blocking SAN and AVN calcium channels. So if we look at this experiment, what they took is they took a myocyte strip, they placed it in vitro, and they stimulated it. And then they measured, first of all, the intracellular calcium rise using a calcium-sensitive dye. And then afterwards, you look at the myocyte tension that's generated as a result of that intracellular calcium rise. So if you look at control, which is demarcated with C, you can see control. You see you stimulate it, you get that intracellular calcium rise, and then later you get the tension generated. But then afterwards, when you superfuse that myocyte with different volatile anesthetics, such as isoflurane, which is labeled I, or halothane, which is labeled H, you see that there's a reduction in that intracellular calcium rise, and you also see a proportional reduction in the tension generated. Now, if we move on to cardiovascular vasodilation, what happens to refresh on smooth muscle cell electromechanical coupling? How it works is that when you activate the alpha-1 adrenoceptor, it converts PIP3 into IP3 and DAG, and the DAG activates non-selective cation channels. And these non-selective cation channels enables a sufficient membrane depolarization to then activate your L-type calcium channel here. And it's your L-type calcium channel is where you get that massive calcium influx, which increases cytosolic calcium concentration and then leads to your smooth muscle cell contraction. And what volatile anesthetics do is that they block the L-type calcium channel, so you get no calcium influx, no rise in intracellular calcium concentration, and hence you get smooth muscle cell relaxation. And then this results in vasodilation, and then you get decreased systemic vascular resistance. And as blood pressure is cardiac output times systemic vascular resistance, you get decreased blood pressure. And now looking at the previous two slides, we're focusing on volatile anesthetics. Now in terms of IV anesthetics, how they affect the cardiovascular system is that they inhibit brainstem circuits, which are involved in maintaining sympathetic nervous system outflow. So on this experiment on the right, what they did is they placed a fine electrode in the patient's peroneal nerve, and they measured efferent sympathetic nervous system activity over here. So what happens is at the point where you inject propofol, you see a reduction in action potential amplitude from those efferent sympathetic nervous system fibers, and that also coincides with a drop in systolic and diastolic blood pressure. And ways in which anesthetists attempt to overcome this cardiovascular challenge is during the operation, if the blood pressure drops, they can administer IV fluids such as Hartmann's fluid. And what you're doing is you're increasing the effective circulating volume, and in increasing that, you're increasing the cardiac output. And as blood pressure is cardiac output times systemic vascular resistance, you're increasing your blood pressure. And you can also administer vasoconstrictors if you've noticed there's been a lot of vasodilation and blood pressure drop, such as, for example, ephedrine you can administer. You can also administer phenylephrine, and you can administer only in critical situations, usually because it's quite potent, adrenaline. And you can also administer to increase cardiac contractility, some ionotropes such as ephedrine and adrenaline. And if the patient is bradycardic, i.e. if they have a low heart rate, you can administer atropine, which is a muscarinic antagonist. And so by doing so, you're blocking the effect of the vagus releasing acetylcholine on the heart and attempting to slow it down. And by blocking that, you're consequently increasing the heart rate. And now in terms of thermoregulation, Um, After the operation, the patients can sometimes have mild hypothermia, and the causes of the mild hypothermia is the vasodilation that we previously mentioned, which increases heat loss from the peripheries. And another cause is the reduced metabolism during the operation, which reduces metabolic heat production. And also the paralysis prevents the behavioral response that we tend to do when we feel cold. And the problem is that it causes post-operative thermoregulatory vasoconstriction. So basically, you get that vasoconstriction because you're mildly hypothermic. So you're reducing blood flow to skin capillaries. And so because you're reducing blood flow to skin capillaries, you're reducing oxygen delivery to subcutaneous sites. And also you're impairing the ability of immune cells to access subcutaneous sites if there's an infection. And so consequently, that causes an increased risk of surgical wound infection. And you can also have post-anesthetic shivering, which can increase oxygen consumption. And in severe cases, it can raise your intracranial and intraocular pressure. And ways in which anesthetists tend to overcome this challenge is to treat post-anesthetic shivering with meperidine, which is an opioid agonist, and it changes the shivering thresholds of the patient. You can also use warming blankets to warm the patient up. And if it's severe, then you could give an oxygen mask because the patient is consuming a lot of oxygen because of the shivering. And now going on to the respiratory effects of anesthetics, now looking at ventilation. So just to recap, what happens is peripheral chemoreceptors and central chemoreceptors detect a drop in PO2 or an increase in PCO2. And when they detect that, they increase their firing to the respiratory center, which then increases the firing to the diaphragm via the phrenic nerve. And this is the chemoreflex loop. And what volatile anesthetics do is that they decrease the sensitivity of the chemoreflex loop to hypercapnia being increased PCO2. So what happens is the chemoreceptors are less able to sense that increase in PCO2, and hence you get weaker response to a weaker ventilatory response to hypercapnia. And volatile anesthetics seem to affect the peripheral and not central chemoreceptors. So if you look at this experiment, they artificially stimulated ventilation in subjects through making them breathe carbon dioxide and gas. And then you can see there's two experiments. There's one, the control experiment, and one where they administer sevoflurane. And what they do is this is the overall ventilatory response, which I've highlighted as ventilation for both experiments. What they did is they used a computer algorithm to break down this total ventilation into a rapid response that's mediated by the peripheral chemoreceptors, and that's labeled as VP. And they also broke it down into a slower response, which is mediated by the central chemoreceptors, and that's labeled VC. And so if you compare control and sevoflurane, and this, of course, this rises when you give that CO2 to the patients, you can see that there's no changes in the ventilatory response from the central chemoreceptors, but there's a halving in the response from the peripheral chemoreceptors, which suggests that volatile anesthetics are decreasing the sensitivity of peripheral chemoreceptors. And if you take that in contrast to IV anesthetics, they affect ventilation as well, but it's through depressing respiratory rhythm generation in the medullary respiratory center. Now, in terms of the response of the effects of volatile anesthetics on ventilation in response to hypoxia, if you look at this graph, the control line, it shows you the normal response you get to low PO2. So what happens is when you get low PO2 at a certain point, the carotid body chemoreceptors sense that, and you get that increased ventilation. And what volatile anesthetics do is that they depress the ventilatory response to hypoxia. So as you can see here, when you reach the hypoxic conditions, there's no change in the ventilatory response. And this is thought to be mediated through the effects of volatile anesthetics on the carotid body glomus cells. So in normal conditions, when you've got normal levels of oxygen, there's reactive oxygen species that is present. And this is because reactive oxygen species is produced when you get aerobic respiration in the mitochondria. So in oxygen-rich environments, you've got reactive oxygen species, and it activates task channels on the carotid body glomerulus cell. And in doing so, it causes potassium ion efflux, and that leads to hyperpolarization of the carotid body glomerulus cell, and hence inactivates it. There's no sinus nerve firing. So just to recap, oxygen-rich condition, glomerulus cell doesn't fire, no ventilatory response. However, in hypoxic conditions, you've got no reactive oxygen species that's present. So task channel is inactivated. So carotid body glomerulus cell is depolarized and sends output to the respiratory centers, and hence you get an increase in ventilation. Now, what volatile anesthetics do is that their metabolism generates reactive oxygen species. So even in hypoxic conditions, you've got reactive oxygen species, which is around, and that means that the carotid body glomerulus cell is hyperpolarized and is unable to send signals to the respiratory center to increase ventilation. So that's thought to be why you don't respond to hypoxia when you're taking volatile anesthetics. And now in terms of gas exchange, just to recap from last year, you've got hypoxic pulmonary vasoconstriction in hypoxic lung regions, which directs blood to more oxygenated regions. And it does so to improve VQ matching. So in better ventilated regions, more blood is flowing, so more oxygen uptake to that blood. And what volatile anesthetics do is that they impair hypoxic pulmonary vasoconstriction. And one theory is that it's due to smooth muscle, due to the effects of volatile anesthetics on smooth muscle cell task channels. So it's a similar situation, but this time we're looking at pulmonary vascular smooth muscle cells and not at the carotid body glomerulus cells. And in a normal condition, when you've got normal oxygenation or when the lung is well oxygenated, you've got reactive oxygen species around, it activates your task channels, causes potassium ion efflux, and your smooth muscle cells, your vascular smooth muscle cells are hyperpolarized. So you get that pulmonary vasodilation in well oxygenated regions, and that maximizes your oxygen uptake. If you are to contrast in hypoxic conditions in the lung, in hypoxic lung regions, you have no reactive oxygen species. So what happens is because there's no reactive oxygen species, inactivates the task channel, you get depolarization of the smooth muscle cell, and hence you get pulmonary capillary and arterial vasoconstriction to limit blood flow in that region. Now, what volatile anesthetics do is that their metabolism, as we have mentioned in the last slide, it generates reactive oxygen species. So what happens is even in hypoxic lung regions, you've got reactive oxygen species around. So you're depolarizing that smooth muscle cell, and you're causing vasodilation everywhere in the lung, irrespective of if it's hypoxic or not. And so you've got less effective hypoxic and pulmonary vasoconstriction, and hence you've got less effective overall lung VQ matching, and this results in overall less effective gas exchange. And now finally, I'm looking at airway patency. Usually when we take a breath in, as we're generating subatmospheric pressure in order to draw air into our lungs, and because the mouth is going to be atmospheric, what happens is that this pressure gradient causes the oropharynx to want to collapse in on itself. So this doesn't happen in the nasopharynx and the trachea, because the nasopharynx is supported by bone and the trachea is supported by cartilage. But this bit wants to collapse on itself every time we take a deep breath in. But what prevents the oropharynx from collapsing in on itself usually is that before the diaphragm contracts, a message is sent to your pharyngeal muscles to stiffen, and it's this stiffening that prevents the oropharynx from falling in on itself. It kind of resists that, and so that's the usual mechanism by which oropharynx doesn't fall in on itself when we're taking a breath in. But what anesthetics do is that they affect the output to those pharyngeal muscles, so you don't get that pharyngeal muscle stiffening before your diaphragm is going to contract, before you're going to take that breath in. So it can cause airway obstruction in the patient whilst that patient still has the central drive to breathe. And so ways in which anesthetists try to overcome this challenge is through airway support. So before the operation, they'll place a laryngeal mask airway or an endotracheal tube into the airway to keep the airway open, and also to more easily deliver volatile anesthetics to the lung. So I think that's it from me. So thank you so much for coming to this lecture, and please, if you can, fill in the feedback form, and if you do so, I'll send the lecture slides, and I'll also send essay plans for asthma and anesthetics. Yeah, thank you very much. Wait, sorry, let me show the link.